to elders past, present and future. The Gadigal, Wangal and Bedigal clans are within these boundaries here at Concord Hospital, Sydney. We acknowledge the stories, traditions and living cultures of Aboriginal and Torres Strait Islander peoples on this land and commit to building a brighter future together. I want to extend a warm welcome to each one of you, both here in person and those joining us virtually, to this Follicular Lymphoma patient seminar and webinar. It is an honour to stand before such a resilient and inspiring community. Yay. My name is Stephen Nasibian. I'm a follicular lymphoma patient here at Concord. I'm also a director and proud committee member of Foundation for a Bloody Great Cause Limited, a foundation dedicated to supporting the Haematology Clinical Research Unit at Concord Cancer Centre. Our mission is simple yet profound: to raise funds and advocate for world-leading haematology clinical research at Concord Haematology, Concord Hospital, finding cures and saving lives. Our journey began with a powerful goal: to provide more patients with access to clinical trials here at Concord Hospital. Over time, our focus has extended to include funding comprehensive resources, championing advocacy efforts, and fostering a supportive community for patients and their loved ones. We are a local initiative and very proud to partner with the larger National Lymphoma Australia, who provides so much support to patients across the country. It is with great pleasure that we welcome Nicole Weeks and Liz Harris from Lymphoma Australia and their patient community who are joining us online. Liz or Nicole, would you like to come and say a few words, please?
Hi everyone, I'm Nicole. I'm from Lymphoma Australia and I work as the New South Wales Lymphoma Care Nurse. So I just wanted to thank everyone for coming today and also for those that are tuning in online. So at Lymphoma Australia, what we do is we support patients that have a diagnosis of either lymphoma or CLL. And we provide patients with telephone support where patients can give us a call, speak to a nurse Monday to Friday. We also have a nurse email where patients can email us questions that they may have related to their lymphoma or their treatment or even their side effects as well. And then we importantly provide fact sheets and information for patients. So many of you may have navigated our lymphoma.org.au website. We update that website to make sure that you guys have the most up-to-date information. We also do support groups which are online and they're also in person as well. So you can always check our events calendar on our website for whatever is up and coming. And then importantly, we do these educational events and seminars. So many are in person, like some of you are here today, or also online as well. So we just want to make sure that every patient with a lymphoma or CLL diagnosis is informed and also that they're not facing this diagnosis alone. So today we're going to have lots of information about follicular lymphoma. And for those of you at home, you may have lots of questions in regards to the talks. So there is a Q&A function, and so just put your questions in the Q&A function and we will be monitoring those questions that we will answer towards the end, and we'll also have a panel at the end. So thank you very much and enjoy.
My journey with the foundation began in 2012 when I joined the fundraising committee for a Bloody Great Night Out with my mum, Mary Nasibian, who battled with another lymphoma, Waldenstrom's macroglobulinemia, and she sadly passed away in November 2022 after 20 years and 3 clinical trials for lymphoma. In December 2021, I was diagnosed with stage 4 follicular lymphoma. It's a journey I never expected, but one that brought me closer to the incredible work we do. A year and a half later, in May 2023, I joined the Petrea clinical trial, and after completing my initial treatment, I received incredible news in December 19th, 2023, I was in full metabolic remission. That day was unforgettable, and it became even more special as I celebrated it with my fellow committee members at our Christmas party that same evening. Together with Lymphoma Australia, we gather with a clear and shared purpose to explore the latest advancements and strategies in the management of follicular lymphoma. Our seminar will be short but impactful as we delve into crucial topics that hold great significance for all of us. We have 5 speakers before our panel Q&A session, where I encourage you to actively participate, ask questions, and share your experiences. Together, we can create a supportive and empowering environment that fosters learning and connection. We will begin by introducing Professor Judith Trotman, my hero haematologist, lymphoma lead and the head of community partnerships here at Concord Hospital. Professor Trotman is also the scientific chair of the Australasian Leukemia and Lymphoma Clinical Trials Group. Today, she will delve into the concept of a functional cure, examining the prolonged survival rates achieved by many patients with follicular lymphoma, debunking many myths and about this incurable cancer.
I want to thank Stephen and also pay tribute to his mother, who was a big lymphoma advocate here at Concord and a pioneering partner in so many of our trials. Now, I have to say that on behalf of all the haematologists who are going to be speaking today, patient education is our happy space. And there is nothing more rewarding than to be talking to the 40 of you face-to-face and the 150 of you online to multiply that education 200-fold. So we really do look forward to this in deep engagement with you. So I'm kicking off with an education session that I gave to my peers at the American Hematology Society, the big global conference that is conducted every year in the US. And this was an education session. And I put my neck out there a little bit because I talked about the pursuit of a functional cure for patients who have this so-called incurable lymphoma. And I renamed this Playing the Long Game. Now, I'm very conscious of the fact that I have laicized a lot of the terminology, but I am otherwise giving you the same education that was given to clinicians. And so I do, while I hope that this will engender a lot of optimism for you all, I also do give you a little warning, because some of the statistics, some of the data may seem confronting. Having said that, however, my key takeaways are going to be that while follicular lymphoma is labelled as incurable, well, so is life. We are all going to die at some time, and our goal as your lymphoma doctor is to delay that as much as possible. And in some ways, if you die of a heart attack or a stroke or dementia at the age of 90, we will feel our job was done, and our job was done well. So while follicular lymphoma is labelled as incurable, there is this sort of outdated dichotomy, this separation between what is labelled as a curable lymphoma and what is an incurable lymphoma. And that, fueled by our limited long-term follow-up data in clinical trials, creates uncertainty for us conservative doctors, and that tends to wire us up for pessimism. Now, I plan to show you how even the limited data we have does support much more optimism, with not just one, but many patients functionally cured. I'm going to share with you my preferred first-line treatment for follicular lymphoma, and chart the survival predictions. We're going to crystal ball gaze for patients who achieve a complete remission, a complete response to that initial therapy, and how that limited prognostic data actually highlights the importance for big data from source, from you, the patients, for robust, very long-term follow-up. So at the patient level, rather than the disease level, I do believe that cure is an underused word in follicular lymphoma. And let's go back to the definition. Let's go back to the Latin cura, to heal, to restore to good health. And that's actually echoed in the US National Cancer Institute Dictionary of Cancer Terms. But the true definition of cure is somewhat elusive, and it continues to remain debated and refined. But we believe that many patients will achieve what I'm going to term as a functional cure and are predicted to die with rather than from their lymphoma. And I'm going to show you the data that challenges our conventional mantra that incurable follicular lymphoma usually requires multiple lines, multiple rounds of chemotherapy, and that disease control is largely insufficient. Now, I recognise the needs of the minority populations who have early relapses or who have multiple relapses, and those populations drive us to develop better therapies in our clinical trials with our drug company partnerships. And that's going to be discussed in detail by Dr. Jan Falconer and Dr. Ryan Lowe later. But the limited long-term data we have does empower us to change the conversation in partnership with Lymphoma Australia and the patient communities around the world, and convey optimism, because many patients with what must now be the most prevalent lymphoma globally will live beyond 20 years. So how has that functional cure become possible? And that's because of the addition of rituximab, the anti-CD20 antibody that targets the CD20 protein on the surface of the lymphoma cells that Dr. Angeline Josiah is going to explain in much greater detail to you later. Now, the seminal PRIMA study of primary rituximab in induction with chemotherapy and as maintenance approach actually is completed its follow-up after 10 years of follow-up. And we have 10-year overall survival estimates from that study of 80% of all participants. Now, back in 2005, Concord Repatriation General Hospital thought that most of our patients with follicular lymphoma would be elderly and frail. And so we chose a very gentle chemotherapy option called rituximab with CVP, cyclophosphamide, vincristine, and prednisone, as our chemotherapy option for the PRIMA study. And we had 10 patients enrolled in that study, and their median age was 58. Their median follow-up from diagnosis is now 17 years, and 9 out of those 10 patients responded to chemotherapy. 5 of them have had a sustained response, and 4 of them have relapsed. And 1 of 10 had what we call stable disease. 6 of those patients have since died. 1 at a young age after transplant complications when he had early disease progression. And 1 just a couple of months ago after a very aggressive transformation of his lymphoma at his 3rd relapse at the age of 89. 4 of them, so more people had died because of the natural other diseases of aging: kidney failure, dementia, bladder cancer, and 1 man who unfortunately got prostate cancer at a relatively early age. And 4 of those patients are still alive, with a median age of 75. So we have, for this population of 10 patients, it's a very small sample, but a long follow-up. what we call a progression-free survival, a median progression-free survival of 6 years. And that term progression-free survival, that those of you who might do a fair bit of Googling might come across, relates to two factors. One, the time from the initial treatment of lymphoma to when it has relapsed or so-called progressed, or death. So it's not just progression, it also includes death from any cause, whether it be lymphoma or heart disease or something else. And our median overall survival was 17 years. What of my one patient who didn't respond, who had what we call a stable disease, whereby less than 50% of the volume of his disease, his lymphoma had shrunk by less than 50% of its volume. Now, this was someone who came to my clinic with significant jaundice due to his enlarged abdominal lymph nodes here. Whoops, all right, the wrong way. There's large lymph nodes here with the circle in red helping you identify his lymphoma. So he had quite what we call is bulky stage 2 abdominal disease. And he was treated in Prima with 8 cycles of rituximab and CVP chemotherapy. And because he had a less than partial response, so was said to be a non-responder, he was taken off the study. And I gave him 30 doses of radiotherapy, which caused significant side effects for this man in his gut for the next 3 months. Nonetheless, I discharged him almost 10 years later from follow-up because he'd never had a relapse. And when I rang him to find out how he was going, he remains very well aged 75 and told me off. Judith, you didn't prepare me to live this long. I've run out of all my superannuation, all right? So I always tell patients when they first diagnose, don't give up your day job. Okay, so what about the outcome of a larger body of patients at Concord who've all consented to provide their data in clinical trials? And we've got a sum of 32 patients who've participated in the Prima, the Gallium, the Bright, and the relevant studies, including some patients in the room today. Now, all these studies have abandoned further follow-up. They're done and dusted after 10 years. They're no longer interested in what has happened to you. The median follow-up of all these patients is 12 years, and almost 70% of them remain in first remission with a median duration of response of 13 years. And you can see in the asterisks up there in red, at 10-year mark, almost 3/4 of them remain progression-free, free of relapse or death from any cause. But the news gets better because we have better treatments in 2025. And I just want to pay tribute here to just a few of the patients who are the people behind the follicular lymphoma publications who are paying it forward for other patients. We have a patient here in 2004 who was a pioneer in the Prima study and was very much, remains in remission and very well and never expected to be so in 2025. We have Ken here, who Ken, I'm very proud. He's happy to share this photo and also to share the fact that he is also a doctor and the director of CareFlight here. And I'm very proud of the fact that this is how Ken got himself a publication in the prestigious New England Journal of Medicine by participating in the relevance trial. So thank you, Ken. And likewise to Hannah and Stephen, your Patria trial participation is paying it forward for other patients. So, many patients who are diagnosed, and this is a talk about advanced stage follicular lymphoma, and Angeline's going to explain a little bit about early stage, but many patients who are diagnosed with advanced stage follicular lymphoma really do panic. And they go to Google and they read about their stage 4 cancer. And it's just not the same as a metastatic carcinoma when you're diagnosed with advanced stage follicular lymphoma. It is a very, what we call, heterogeneous disease with a very varied presentation and varied patients. So while you fret about your advanced stage, we as doctors are fretting over the multiple inadequate prognostic factors that we have that Angeline will share with you soon. We grapple with the historic treatment criteria and the patient factors, the variability in the patients that affect our therapeutic decision making. So let's go back to the patients who don't need treatment at the start. The patients with advanced stage disease that's just sitting there and not causing any problems. Now, that is estimated in different trials to be anything, different population data sets, to be anything from 20 to 40% of the population. So let's say about a third of patients, when diagnosed with their advanced stage follicular lymphoma, are told, we are going to watch and wait, or give you active monitoring of your lymphoma. Now, population data does vary, but 40% of patients who underwent that watch and wait approach had not commenced therapy at a median follow-up of 8 years. And in a prospective UK trial that we participated in here in Concord and across Australia within the ALLG clinical trials group, almost half of those patients had not needed treatment at 3 years and a third at 10 years. You're going to hear more about rituximab monotherapy, rituximab on its own without chemotherapy later from Angeline. But suffice to say, it is an antibody that specifically targets the CD20 antigen or CD20 protein on the surface of the lymphoma cells. And it triggers off a whole immune reaction that kills those lymphoma cells. So if we were to offer rituximab to a patient instead of watch and wait, the overall survival is no different. So in that UK study I was talking to you about, the patients who were treated with rituximab had a 10-year overall survival of 80%, a familiar theme, a familiar number that you're going to hear quite a bit about, and a lymphoma-specific survival of approximately 90%. And that was not statistically significantly different to the patients who underwent watch and wait. And for the patients who just had rituximab given weekly for 4 doses alone, or given weekly for 4 doses followed by maintenance rituximab, a third of those assigned to retreatment, so just the 4 cycles alone, as well as 2/3 of those, 70% of those who received the maintenance approach, remained in first remission during the 7-year follow-up of that study, with again no difference in overall survival at 10 years. But we do accept that for some patients, watch and wait becomes watch and worry. And the tolerance, the delay, the kicking the can down the road cartoon that I've got there, and the low cost of rituximab monotherapy in 2025 has appeal. But I do warn my patients that may exclude you from participating in a clinical trial of frontline therapy of a novel treatment years down the track if you use rituximab initially at the beginning. And also, philosophically, many of us in Australia believe that the best therapy is the one you don't need in such a rapidly changing therapeutic environment. And we tend to use the years of watch and wait, and there is data to support that prehabilitation during watch and wait is very, very valuable. Perhaps the most affirming statement for a patient who presents to me with advanced stage in 2025 is that modern survival is now so prolonged, I cannot give them reliable survival estimates and can only extrapolate from 10-year follow-up data. Now, there is research done by our breast cancer colleagues here at Concord that shows that patients diagnosed with an incurable cancer prefer the presentation of a scenario-based estimate rather than that median survival that I'm talking to you about. And patients prefer the presentation of a best case, worst case, and most likely scenario-based estimates. Now, applying this approach to the fit 64-year-old, the median age of diagnosis of follicular lymphoma, our conservative best case scenario is that a functional cure will occur for patient with minimal impact on their life expectancy, with a life expectancy of over 20 years. The most likely estimates of 12 to 18 years for the middle 50% of patients arguably reflects a functional cure for many of them as well. And the thing that we tend to focus on most when we do our Google search and most when we think about clinical trials is that worst case scenario minority, the patients who live for less than 5 years. Such best estimates conversations help provide you with agency and a basis to assist you in deciding when to start therapy, the choice of therapy, and the use of rituximab or obinutuzumab maintenance antibody therapy. And that shared decision-making is informed by that PFS, by that progression-free survival data that is so essential for our drug registration trials. But it is more weighted to other arguably more relevant endpoints to you, such as the time to next treatment, overall survival, and what we call the FTOX, the efficacy toxicity trade-offs between therapies. And such robust survival predictions help us in horizon scanning and the potential sequencing of therapies if you need to have other therapies later in your life. So, for those of you who are keen to hear my favourite immunochemotherapy option, I don't have one. Because with such heterogeneity, such variety in disease and patients, it's not a simple paradigm. And I want to remind you again that the one certainty we have in first-line therapy is that the clinical trials show no clear difference in overall survival based on our choice of whatever antibody chemotherapy recipe, whatever combination we use, or whether or not we use maintenance. But that's not good enough to the patient sitting in front of me, helping them make their decisions. So I want to tell you that I am very much guided by the 7-year follow-up data from a large clinical trial that many of us in Australia participated in called the Gallium study. And that suggested that this therapy here, obinutuzumab and bendamustine, gives the longest progression-free survival of 85% at 3 years, with 87% free from next lymphoma therapy at 3 years, and 3/4 of them free from next lymphoma therapy with the longer-term follow-up of the gallium at 7 years. So that weights my personal recommendation, and generally the recommendation of the team, the haematologists sitting here in what we call our war room, the multidisciplinary team meeting, when we're looking at the biopsy results on the screen there, and we're looking at the PET scan, and we're hearing a presentation about who you are and your physical other health issues and your social circumstances. So for our young fit patients, we tend to use obinutuzumab and bendamustine because of that efficacy toxicity trade-off. There is no hair loss, there is no cardiac toxicity. So similarly, a bendamustine-based approach is appealing for the older patients as well, But those, as they get sort of above 65, we start dialing back on the intensity, and we prefer to pair rituximab, the more gentle antibody, with the bendamustine compared to obinutuzumab. But a significant concern of bendamustine is its long-lasting suppression of the lymphocyte counts, the T lymphocytes that help protect our immunity. And there are more adverse effects when paired with obinutuzumab. So that's why we use the rituximab as people get older. But then there's also the other elephant in the room that exists for so many patients with follicular lymphoma, and that is the small minority who in their lifetime develop a transformation of their indolent, their slow-growing lymphoma to an aggressive lymphoma. And when that happens, we want to use a CHOP-based approach because it is more effective for and tried and true recipe for treating aggressive lymphoma. And then we move on to the patient over the age of 70, and particularly those who may have acquired not necessarily an additional health problem, but are starting to get a little bit frail and a little bit less active. And we know that the efficacy toxicity trade-off starts getting too high. And the mortality, the risk of dying in the next 10 years from lymphoma is almost equaled as the risk of dying from other causes, and in particular, the treatment itself. And so for those patients, we tend to combine obinutuzumab with CVP or rituximab with CVP for the very frail patients. So how do we then, after having used that chemotherapy antibody combination, and Angeline's going to dig down deep into the details about those different recipes for treating lymphoma in a little while, but how do we now prognosticate after that initial therapy? We use what is called a PET scan, which is a combination of a functional nuclear scan, a glucose-labeled scan, along with the standard anatomical scanning of the CT scan. And indeed, at Concord, we were very much involved in establishing PET scanning as the gold standing imaging modality to assist in prognostication, both at baseline and at the end of treatment. And this is where we get a bit wonky as doctors, because we call a complete response, we call a complete remission a negative PET scan, when we can't see any of that black stuff, all those black spots from someone who's presented here on the image with advanced stage follicular lymphoma. Or you might, those of you who've read your PET report, see that there's a Deauville score 1, 2, or 3 suggesting complete remission. Now, 90% of patients, so the vast majority of patients, achieve a complete metabolic response. And the long-term follow-up from gallium tells us that 90% of these patients are alive in 7 years. But even if you don't achieve a complete response, don't forget that still a number of patients remain alive at 7 years. And so while PET is better at helping us to identify the patients most likely to live long, it is not perfect. How does institutional and population data help us prognosticate? We have single institution data from 1,000 patients in New York, and the estimated median overall survival at the estimated overall survival at 15 years is 65%, so 2/3 of the patients. Similarly, in an amalgamation of 13 different trials of 5,000 patients, the 10-year overall survival was 80%. And in another study of French and US cohorts, again, we had the same 10-year overall survival of 80%. Perhaps the most reassuring message comes from that very same study, because if you haven't had progression, if you haven't had a death or a problem in that first 2 years after initial treatment, you actually have age and gender matched survival equivalent to the general population. A question that patients often ask me is, how many times am I going to have to go around with this? How many lines of therapy am I going to receive? Now, across Sweden, albeit with short follow-up of 7 years of almost 1,800 patients, 20% of them remained on watch and wait, 10% received radiotherapy alone, and of the 70% who received a first intravenous chemotherapy antibody therapy, you can appreciate that of those, only 40% of them received second line, 18% third line, and 7% fourth line. So it is not inevitable that you will receive multiple lines of treatment for your follicular lymphoma. And a US study similarly had similar results, with 90% of their patients. The US are a little bit more aggressive and quick to the mark than the Swedish are. So 90% received first-line therapy and only a third of them received second-line. And there is simulation data that we have for long-term survival. And in this Finnish and Spanish hospital cohort of 700 odd patients, there was what we call a simulation over 20 years. And it forecasts a nice, easy to remember 1-to-1-to-1 ratio, whereby 1/3 of patients will receive no treatment or only one treatment, 1/3 will receive 2 lines of treatment, and 1/3 will receive 3 or more lines of treatment. Again, the median overall survival is predicted to be 15 years, and 20 years after diagnosis, it is estimated out here that 70% of patients have died, with death from lymphoma in yellow here and other causes equal. So the mindset of a possible functional cure for many sets the scene for tapering follow-up. Mindful that I said to you that antibody maintenance has a clear progression-free advantage but no overall survival advantage at the cost of increased low blood counts and infections, I started only in the willing and the well. And I will have a low threshold for stopping it for toxicity, particularly in the elderly. And I always, particularly in this post-COVID era, make sure it fits with your post-induction travel plans. Specifically in patients who are young, with dependents or important work priorities over the next decades, and expectations from the PRIMA study of the time to next treatment being more than 10 years, I will push through with their maintenance and occasionally give them injections with G-CSF to stimulate a good neutrophil count if their neutrophils get low. And with 2 monthly nurse and 4 to 6 monthly hematologist follow-up during maintenance, we are reverting earlier and earlier to patient-initiated follow-up, which Dr. Ryan Lowe is going to be explaining further to you in a subsequent talk. Finally, I want to speak directly to those of you who are younger, because 1/4 of our patients are aged less than 55. And our survival estimates are inadequate to assist life planning for these patients. The sandwich generation, who in addition to their own aspirations, have care responsibilities to both children and elderly parents. And it is insufficient to tell them, it's almost insulting to tell them, I'm 95% confident you will be alive in 5 years' time. It is inadequate. Similarly, an 8-year survival estimate for the 6% of our patients who are aged less than 40 is inadequate. Now, an increasingly mobile patient population with growing digital natives amongst us, everyone's got a smartphone. This is creating limitations to our traditional registries. And we believe we can address this with contemporaneous patient-derived data. In pursuit of living longer and living better, these self-recorded metrics will be a productive channel in, as I said, a world where everyone has a smartphone. And we've got experience with this, with our 700 patients, with our global WM study of a much rarer lymphoma than follicular lymphoma. And we've also just gone live with the My Hodgkin, My Health app in Australia, with a rapid uptick in recruitment after a Lymphoma Australia. Thank you, Liz and Nicole. We had a webinar a month ago, and you see the rapid uptick in recruitment that we had after that. And our learnings from Whimsical and from My Hodgkin's, My Health will inform us in the rollout of Followed for Life in 2026. And we have several leading international follicular lymphoma investigators ready for us to go global with this. Just a couple of slides about My Hodgkin, My Health as a proof of concept for Followed for Life. It flips the traditional research model and it puts you at the centre of driving the research. It's a mobile phone app. Patients can enter data from their own home and become partners in research. This is an image of our beta testers before we did the rollout of My Hodgkin's, My Health. It empowers you to understand your post-lymphoma health better, and it's a technology that obviously can be easily upscaled to thousands of users, both Australia and globally. Patients will download the app from the Apple App Store or Google Play. They self-screen for eligibility, read the information consent document and sign the digital consent form and complete the baseline questionnaire. And they will receive a summary of their own responses emailed to them for their own health record. And of course, this is a scientifically and ethically approved patient-physician research partnership with de-identified data and very stringent data security protocols. I want to finish by highlighting a patient who was young with relapsed follicular lymphoma. And when I was in medical school in 1992, this 29-year-old presented with bulky abdominal disease. Again, you see the abdominal disease shown here. This predates even rituximab, and she just had CHOP chemotherapy alone and obtained a complete response. When I became her haematologist, I was imaging her every 2 years because back then we were all in that sort of sense of it's inevitable she's going to relapse and need new treatment. And she indeed did have a relapse in 2007. But it took another 4 years before that relapse reached a point where we agreed it was time to give her new treatment. We gave her rituximab with CHOP again, followed by CVP because she had reached the limits of her anthracycline, the cardiac toxic medication, and she obtained another partial response and has had waxing and waning abdominal disease over the last 13 years. And 31 years after her initial diagnosis, she's gone from being 29 to now being 60. And we just did a little biopsy during weight reduction surgery. And sure enough, her follicular lymphoma was sitting there stubbornly indolent. Now, the mindset in 1992 would not have set this woman up for a concept of a functional cure. But in 2025, with the advent of novel therapies, suggests this might be possible. And it's arguable that it's our youngest patients who have the greatest reward to risk ratio from the introduction of these novel therapies that Janelyn's going to be telling you about, aimed at a deep response and the potential for a true cure of their follicular lymphoma. So let's conclude by hoping that I have shifted your mindset just a little bit. Follicular lymphoma may remain incurable, but we do have data that suggests many patients are functionally cured. And while we have limited trials and population-based survival data, that limited data can frame more optimistic prognostication. Our challenge remains identifying more accurately the population for whom will have greatest benefit from novel therapies. and our prolonged survival predictions for patients in first and in second complete response based on data and our own experience, our own internal machine learning and pattern recognition does help us to crystal ball gaze. But we need to be better than that. We need genuinely long-term follow-up data with big data from source, from our patients and their carers to confirm that indeed they are playing the long game. And with that, I want to thank you, and in particular thank Janlyn Falconer, who is my co-author in this American Haematology manuscript and presentation, and all the lymphoma team here at Concord Hospital.
Next, Dr. Angeline Josiah, an early career haematologist and foundation-funded lymphoma fellow, joining the Concord Haematology Unit in 2025 after completing her training at Westmead Hospital. Angeline will more deeply examine the principles of first-line treatment and supportive care. Thank you.
Thank you so much, Stephen, for the introduction. Thank you, everyone, for being here. We're very pleased to have this talk today. So I'll just start off by explaining what follicular lymphoma is, and most of us here are fully aware. Follicular lymphoma develops in the white cells, and particularly the white cells that we call the B cells. B cells are made in our bone marrow, so that's the spongy part in the middle of your bone. They usually live in the lymph nodes, and the lymph nodes are all interconnected around our body in what we call the lymphatic system. The B cells travel through the lymphatic system to fight diseases and infections in various parts of the body. When follicular lymphoma develops, there is a mutation in one of these B cells. The abnormal B cells could be contained in a lymph node, but they could also get out of that lymph node and move to neighboring lymph nodes. The abnormal B cells could also then progress to different parts of the body through the lymphatic system. Follicular lymphoma can affect the bone marrow, meaning that some of these abnormal B cells can move into the bone marrow. When this happens, it interferes with the production of the normal cells in our body. Some of these cells include the platelets, and these are the cells that help our blood to clot. The other cells that could be interfered with are the red cells, which help to take oxygen around the body. When a patient has follicular lymphoma, one of the most common ways in which we see this patient is when they come to the clinic with a lump. The lump is usually painless. It could be in the neck, under the armpits, or in the groin area. The patients may also present with other symptoms that are related to compression of organs due to lumps and masses. The symptoms could include a chronic cough, some chest pain, problems with breathing, pain in the abdomen, or back pain. Lymphomas also cause symptoms that we call B symptoms, not usually in follicular lymphoma, but it can happen. And this include a fever for no reason, drenching night sweats, and unintentional weight loss. Patients could also present with fatigue, frequent infections, and bleeding due to invasion of the bone marrow by lymphoma cells. To diagnose follicular lymphoma, we would usually send a patient off for a biopsy. There are different ways in which this biopsy could be performed. When there is a large lymph node that is easily accessible, the radiologist will put in a needle guided by an ultrasound or a CT scan and get a core of that lymph node. Once in a while, it's very difficult to access these lymph nodes. They could be deep in the body, or we could get a core biopsy and not get sufficient cells. In this case, we would send patients off to a surgeon. And what the surgeon would do, they would excise the lymph node under general anesthetic. One advantage of this is that we have sufficient material for our pathologists to review and come to a diagnosis. I put a few pictures of what we would see under the microscope when we look at follicular lymphoma. The first picture on the far right shows us small cells, and we would call that a grade 1 or grade 2 lymphoma, where the cells are mostly small. Further down the line, we have more advanced lymphoma, a grade 3A or 3B. In this situation, there are larger cells there that are more aggressive, and this could influence how we treat the follicular lymphoma. As part of our diagnostic workup, we would send our patients to have a CT scan as well as a PET CT scan. And as you can see on the photo, the PET scan lights up with areas of lymphoma. As Professor Trotman alluded to, once we have treated, we will compare this initial PET scan with a PET scan performed after treatment. So when we're thinking of treating follicular lymphoma, we think about the extent of the disease. Where exactly in the body is follicular lymphoma? And this is what we refer to as the stage of the lymphoma. We use a landmark, which is the diaphragm, that divides the chest and the abdomen. When we have lymph nodes or areas of the body that are just affected in one region, we would call that stage 1 follicular lymphoma. When we have lymph nodes in 2 regions, still above the diaphragm, we would refer to that as stage 2 lymphoma. When we have lymph nodes both above and below the diaphragm, we would refer to that as stage 3 lymphoma. And when we have affected areas that are in lymph nodes and outside of lymph nodes, we would refer to that as stage 4 follicular lymphoma. We also try to predict how the follicular lymphoma will behave. And there is an international scoring system called the Follicular Lymphoma International Prognostic Index. It looks at 5 different factors, and if a patient has any one of these factors, they get a score of 1. The greater the score, the higher the risk of the lymphoma. The factors looked at are the age, greater than 60 years, more sites affected by the lymphoma, certain blood tests that we do in the lab, and the stage of the lymphoma, if it's a 3 or a 4. Now, we largely have 3 situations when a patient comes to us with follicular lymphoma. They could have a stage 1 or 2 disease where it's localized. They could have stage 3 and 4 disease where it's widespread, however, they have no symptoms. And it could also be stage 3 and 4 where the patient has significant symptoms. Now, the choice of treatments depends on some of these factors that we've spoken about. The stage, the symptoms that the patient has, the side effects of our treatment, the age of the patient or their medical conditions, and also the patient choice in discussion with the patient and their loved ones. In certain situations, we do need to do a bone marrow biopsy in addition to the lymph node biopsy. This is particularly in stage 1 and 2 when we're thinking of treatment to ensure that the bone marrow is not affected by follicular lymphoma. We could also perform a bone marrow biopsy when there are abnormal blood counts to investigate the cause of that. So when we're thinking of stage 1 and 2 follicular lymphoma, because this disease is localized, studies tell us that radiotherapy is a good treatment for stage 1 and 2 follicular lymphoma. To perform this treatment, we would refer you to part of our multidisciplinary team, a radiation oncology expert. Radiotherapy works by using mostly X-rays. X-rays have high energy, and they will target the lymphoma and kill off those lymphoma cells by targeting the DNA. The X-rays can also release toxic molecules that will affect the lymphoma and result in the death of the cancer cells. The lymphoma cells are more sensitive to radiotherapy than the normal cells. Radiotherapy has some side effects, and one of the most commonly seen one is a rash that we refer to as radiation dermatitis. And at the top, there are two photos there of patients who've had some radiotherapy with a rash. Other side effects include sores in the mouth or the throat, which we commonly refer to as mucositis. Patients also complain of fatigue as they undergo the radiotherapy process. Then, depending on the site that received radiotherapy, you can have diarrhea, trouble swallowing, and there's also a small risk of a second cancer. Then when we think about stage 3 and 4 follicular lymphoma, where a patient has no symptoms, we think about watchful waiting, also referred to as watch and wait, also referred to as active monitoring. As Professor Trotman said, it could be several years before a patient ever needs treatment. There could also be a chance that a patient never needs treatment. And our treatments do have side effects, so if we can avoid that, we would avoid it. During a period of watch and wait, we will regularly see the patients in the clinic, perform blood tests, we will ask the patients to tell us about any new symptoms they've experienced, and we'll encourage them to focus on a healthy lifestyle, ask questions, be a part of a support group, and tell us how you're doing. When we think of advanced stage follicular lymphoma, stage 3 and 4 with symptoms, the symptoms we're thinking about are those that I spoke about, such as B symptoms, the fever, the unintentional weight loss, the excessive fatigue, then large masses larger than 7 centimeters, lymph nodes in various parts of the body, symptoms of compression of organs, fluid in the lungs or in the abdomen, unenlarged spleen, abnormal blood counts, and these follicular lymphoma cells being seen in the blood as well. These would be reasons for us to begin treatment for follicular lymphoma. Now, our treatments are generally referred to as immunochemotherapy. We combine two types of treatments: the immunotherapy that targets the lymphoma cells, and chemotherapy. Immunotherapy, the ones we mainly use are rituximab and obinutuzumab. And I've got a little drawing there that shows the yellow cell is the lymphoma cell. It's got its signature there with the CD20 in purple. Our rituximab comes on and tags on to that CD20 because it's specific for that area, and it activates the immune system to then release various factors that target the lymphoma cell and cause the death of that cell. When we think of chemotherapy, we use a mix of drugs, and these chemotherapy drugs, they target rapidly dividing cells. Lymphoma cells are rapidly dividing, and they will be affected much more than healthy cells. Because healthy cells could also be affected, this can result in unwanted side effects. The chemotherapy is administered in cycles, for example, 21 or 28-day cycles, allowing the body to recover from the chemoimmunotherapy. So once we decide on a course of therapy, it is also divided in 2 stages, and we've already been introduced to induction and maintenance therapy. The aim of the induction therapy is to deliver high-dose chemoimmunotherapy to reduce the size of the tumor and kill those lymphoma cells. The maintenance therapy is to ensure that the patient can stay as long as possible without lymphoma recurring. The induction therapy would usually be 6 to 8 cycles, usually 6, every 21 or 28 days, depending on the combination we choose, and it will be an intensive treatment. I will give us 3 examples of combinations that we use. So Professor Trotman already referred to them. We have bendamustine and obinutuzumab. Once a patient is commencing therapy, our clinical nurse consultant, or in any of our hospitals, is always there as a good support person to provide education about what is expected during chemotherapy. With bendamustine and obinutuzumab, they're both delivered through a drip. You will notice that in the first cycle of treatment, the obinutuzumab is delivered on day 1, day 8, and day 15. Day 1 is always a long day because it could be associated with some immune-related reactions, which I will speak about. Bendamustine is delivered on day 1 and day 2. For the rest of the cycles, the treatment is delivered on day 1 and 2 for 6 cycles every 28 days. Some of the side effects include the infusion-related reactions, which I'll speak about, low blood counts, abnormal blood tests, the risk of infection, and the possible risk of a second malignancy. When patients receive immunotherapy, they can have various reactions related to the activation of the immune system. This can include fevers, sweating, chills, a skin rash, shortness of breath. They could be more serious, including a low blood pressure, facial swelling, and inability to breathe. So prior to administering the immunochemotherapy, we will usually give supportive drugs, and this include paracetamol, some steroids, antihistamines, and adequate hydration. So we'll give you some fluids through the drip. Another option that we have is the OCHOP, which includes the obinutuzumab immunotherapy, some steroids, which are tablets in tablet form, cyclophosphamide, doxorubicin, and vincristine. Once again, for our chemotherapy drugs, we will require a drip and a cannula, as well as for the obinutuzumab, and the prednisolone will be taken over 5 days. This is delivered every 21 days for 6 cycles. The main side effects to think about are taste disturbances. They could be burning on urination. The doxorubicin can have an effect on the heart. The prednisolone has effects including weight gain, mood disturbances, and high glucose. And the vincristine could have effects such as numbness, pins and needles, and constipation. The third combination that I presented here is obinutuzumab, cyclophosphamide, vincristine, and prednisolone. So in patients who have a known history of cardiac disease, are frail, or have an increased risk of cardiac toxicity, we would use this kind of regimen. So clearly, we will tailor the regimen based on the patient. So we talked about infection as a risk of some of our treatment, and we give various antibacterial or antiviral medications to reduce the risk of infections. So some of our patients will be familiar with Resprim, which is a tablet you take to prevent pneumonia caused by a certain bacteria. Antivirals such as valacyclovir, which helps us prevent shingles and HSV infections. We also use a tablet called entecavir to prevent activation of hepatitis B in patients who are previously exposed to hepatitis B. We also encourage patients to have a Shingrix vaccination to prevent against shingles. The other supportive medication is one called allopurinol, which we may only use for the first cycle. When the cancer cells get exposed to treatment, they die, which we refer to as lysing, and their DNA is released. When that DNA is broken down, it increases the uric acid that's present in the blood, and this can form crystals and interfere with the function of the kidney. To prevent this, once again, that's the role of the hydration that we give you, or we would encourage you to drink adequately during those first days of treatment, and we'll give a medication called allopurinol. Other supportive medications, because we know patients can get constipated, we would encourage things such as Movicol, eating a healthy diet, having fiber in your food, various anti-nausea medications, and a mouthwash. It's a daily regular mouthwash for our patients on chemotherapy. Other things that we focus on in supportive care are appetite and nutrition. We know that some patients feel off food during this period. So we'd encourage you to take small meals throughout the day rather than 3 large meals at a time. We have dietitians at various hospitals who can support us. We have supplements such as Ensure that patients can have. We spoke about the bowels. During the chemoimmunotherapy, we also gave anti-nausea medications to help. With fatigue, we encourage patients to still try and keep as active as possible. Go out in the sun and maintain your normal sleep-wake cycle, exercise as tolerated, and interact with family and friends. With regard to sex and intimacy, patients do have questions, and this is something that they can navigate with their partner as well as with our clinical nurse consultants. There's access to quite a lot of support, both within the hospital and in support groups and organizations. Patients should always feel comfortable to ask the doctor or the nurses about these resources that are available. Once the treatment is complete, that's the induction therapy, we'll have a PET scan to review the response to treatment. I've put up a PET scan there that shows a patient who had quite prominent lymph nodes, and post-treatment, they had clearance of that lymph node, of those lymph nodes. That's what we'd like to see. The maintenance treatment that follows is then through immunotherapy. We'll either use rituximab or obinutuzumab every 2 months for a duration of up to 2 years. We'll monitor patients every 3 to 6 months in our clinic for up to 5 years, and this includes asking you what symptoms you've been getting. We'll perform a physical exam and we'll perform blood tests as well. We don't routinely do CT scans unless you tell us that there are symptoms of concern or we see an abnormal blood count, or during our physical examination, we find something unusual, then we'll investigate further. Thank you very much.
Thank you, Angeline. Now it's my pleasure to welcome Dr. Ryan Lowe, the Foundation-funded research fellow from the UK, who will map the current and future clinical trial approaches in follicular lymphoma and address the concept of patient-initiated follow-up.
Hello, everybody, and thanks, Stephen, for the introduction. So my name is Ryan, and I am one of the haematology doctors here, and I work in the clinical trials team, and it's lovely to see some familiar faces in the audience. And also, it's really lovely that there's so many people here today who are so engaged in wanting to learn about your disease. It's really inspiring to see, actually, as a doctor. So, thank you for coming. As Stephen said, and you may guess from my accent, I'm not from Australia. I'm from the UK, so that's where I've done my haematology training. I'm going to talk about a concept called patient-initiated follow-up, or PIFU for short. And it's about putting you in charge of your care. And this is something that we've been doing in the UK, in the NHS, for a long time now, actually. And it's slowly becoming sort of increasingly popular throughout the world. And I know some of you may even be on it in Australia, but without realising that it's got this specific name. But it's likely to be something that is going to become more popular as time goes on, as there are more restraints on the healthcare system. So my aim today is to talk to you about what PIFU is, okay, how it works, what the pros of it are, what the cons of it are, and really sort of maybe in the sort of question and answer session about what your thoughts are and what your concerns are about it. I think that probably would be what's most interesting to us. So what is PIFU? So it's essentially a model where patients take the lead in initiating their own follow-up, okay? And the appointments are based on your health needs and your symptoms. That's rather than these scheduled routine visits, okay? And it offers sort of support and education for you to take charge of your own care and well-being. And it replaces these sort of 3 monthly, 6 monthly follow-ups that you may be having with your haematologist. So how does it work? So Judith and Angelina have been through, so you'll have your initial diagnosis of lymphoma, and obviously at that time that's quite a scary and worrying time, and we often see you quite frequently at that point. And not everybody with follicular lymphoma will need treatment straight away, as we've heard. So you go into this sort of observation or watch and wait or watch and worry, as we've had sort of, and that's usually maybe every 3 months. And you'll see your doctor and have a review and check in on your symptoms. And at some point, you may need treatment. And then the frequency of your appointments will become a bit more intense, and you'll be sort of coming once a month and needing more frequent reviews. And hopefully, once the treatment's done, you've had a good response, you'll be in this observation period where we typically see you maybe every 3 months for a year, and then maybe it goes to 6 monthly, and then that's ongoing. But there will become a point, hopefully, where as Professor Trotman has said about playing this long game, where your lymphoma will be controlled, you don't need any treatment, and fingers crossed your health is good, and you've not had any particularly sort of long-term side effects from the treatment that we need to be keeping an eye on. And we'll approach you and talk to you about this concept of PIFU, where we will think about discharging you from clinic, and then you telling us when you want to be seen again, okay? And that can be quite a scary thing, and I appreciate that. Sort of, you're so used to coming to see the doctor and discussing your things, but it's about putting you in charge and sort of empowering you about your care. So if we think this might be appropriate for you, we'll sit down. We'll have a talk about what this means. And there's 3 really important points that if we think that PIFU is appropriate for you, that really should be discussed, and we should spend a lot of time talking about. The first one is education. The second one is having clear guidelines that you're happy with. And then the third one, and I think one of the most important ones, is about communication and having good communication links to us and being really sort of happy that you know how to do that. So I'm going to talk through sort of these 3 things that are really important if you went into a sort of patient-initiated follow-up. So the first one is education, and you guys are all doing that by just being here today, but understanding your disease and being really confident about sort of what you should be aware of. And you'll have picked up on this as you've gone through all your clinic appointments, because we'll ask you the same questions again and again, okay? So most patients know what questions we're going to ask them when they come through the door. So having an understanding of your own body, and as Angelina said, there's symptoms that we worry about are any lumps or bumps that you may be able to feel, that you're losing weight without without intentionally not trying to lose weight, feeling quite tired and worn out, and then the drenching night sweats. Again, questions that we'll ask you time and again. But we really want you to be clear that these are the signs and symptoms that you should be looking out for, and that you should get in touch and contact to initiate a follow-up appointment, okay? But also, and some of you in this room will be in a situation where you actually didn't have any of these symptoms when your lymphoma was diagnosed. It may have been something different. And talk to your haematologist before you went on to patient-initiated follow-up about that. So things like if you presented with lymphoma and it was a back pain that you had for a few months. If them symptoms come back again, that's the time to pick up the phone and come back and see your haematologist. So education, super important. The second one, communication. And this is about what you do when you have any of these symptoms or any of these worries. And this, as I said, this to me is the most important thing. And this is where, if you went on to a patient-initiated follow-up, it needs to be really clear about how you can get in touch with us. And usually for the patients here at Concord, I think most of you will have met Alicia. And if you were in Concord, that would be your first point of contact, speaking to the nurse specialist, okay? And usually, I said, Alicia's great, and she will be able to troubleshoot some of these problems, and you may not even have to come and see a haematologist. But also, but if you do need to, they're the first point of contact to get you into clinic as soon as you can. And then if you're struggling, things like getting through to the consultant secretaries and booking in, I know that's way more difficult, so I definitely want to try and get through on a CNS. But it's about, I said, it's our job to make sure you feel really comfortable about who to contact if you went into this, into a patient-initiated follow-up. And that's where clear guidelines come into play. As I said, in the NHS, this has been something that we've been doing for a long time. So a lot of the hospitals in back home have really specific and really helpful guidelines that when we think that you'd be appropriate for a patient-initiated follow-up, we'll give you this booklet, and it will have all them symptoms I've discussed about, and then really clear things on how you will get in touch with us if you want to come back for a follow-up. Because sometimes the worst thing, the anxieties that patients have brought up before is, say if they try to call the clinical nurse specialist and they don't answer. What do I do? Okay, if that's the only contact. So we give you multiple ways of being able to get in touch, because we don't want people sat at home not being able to get in touch if there's something that's worrying them. So they're the three things that if a doctor sort of says to you, I think I might sort of think about patient-initiated follow-up, that you want to make sure that you have good education on what you're looking for, clear guidelines on how you get in touch with us, and a good communication link to your team. So I guess that comes to why has this come about? Why would we want to use patient-initiated follow-up? And the main thing for us is it empowers you guys. You know, it's about you taking an active role in your health, in your decision-making, and leading your care. And also reducing unnecessary appointments, okay? We know, and sometimes you've covered it, there's not very much to say, okay? And some people, especially in Australia, which I've learned, people travel so far to come to their appointments, and often we're not really talking about very much, and you could just as easily, if you have problems, pick up that phone and then initiate your appointment. So that reduces costs, it reduces time. So they're the two main things. But then also, you have to, one of the main reasons it came with the NHS, to be honest, was to try and address the strain that's on the healthcare system. And that's something we can't ignore. There is increasing strains on the healthcare system. And by using something like this, where patients are able to initiate their follow-up, that creates space for when you need an urgent appointment, you can be seen as soon as possible because we've cleared some of the routine appointments that didn't really need to happen. So it's about sort of reducing that strain and improving the efficiency in healthcare. So what's the evidence? And there is evidence, okay? As in medicine, we don't just do things without sort of making sure that we're doing the right thing. And in the UK, as I said, we've been doing this for a while, so we've been able to collect data. And there have been studies where they've looked at patients who've gone onto this patient-initiated program to make sure that the patients who are on that program and the patients who stay in routine follow-up, was there any difference in the time at which a relapse or a recurrence of their disease came through? And there wasn't, okay? So the patients who were on the PIFU, it was just as effective at relapse detection, so your disease coming back, as the standard of sort of care follow-up that you would have. And there's been multiple studies. There's not just one. There's multiple studies that have showed this, and that comes from the UK and both international studies as well. It would be wrong of me not to talk about the challenges or the concerns about this. And so the number one would be patient anxieties. And I totally get that. I would be exactly the same in your position if you were seeing the doctor on regular and you knew you had an appointment. If we just turn around and say, actually, now you tell us when you want to come. That is going to cause great anxiety, but that's where it's our job to help relieve that anxiety by making sure you're well educated and you know how to get in touch with us if there's problems. But that's why I want to hear your thoughts when we come to the afterwards where you can ask us questions. I'd love to hear if this does make you anxious or what your anxieties are, because when this does become more commonplace, we need to make sure we've got the infrastructure in place to help with that. So, to conclude, it's PIFU or patient-initiated follow-up. It is evidence-based, okay? So we've got evidence that this is an effective way of following you up. And I think this is something that really would be helpful in Australia, okay? Because people do travel so far to the appointments, and we do have the infrastructure to have teleconsults or video consults if they're needed, okay? So with careful implementation and education like this, these sessions like this, which we should continue doing, because I think that's really part of this. I think it has potential to be successful. I was going to say questions, but I think we're leaving that to later on, okay? So yeah, please think of questions and then we can talk about it later. Thank you.
Lastly, we'll explore what is in the pipeline for treatment of relapsed follicular lymphoma. Dr. Janelyn Faulkner, Medical Director of Concord's Transplant Service, served as Concord Haematology's inaugural clinical trial research fellow before moving to the UK. There she became departmental lead of clinical research and acute oncology in Southampton within a large CAR T-cell therapy referral centre before returning to Concord in late 2023. Her insights into emerging therapies and ongoing research offers hope and inspiration for those facing relapse.
Good evening, everybody. It's such a pleasure to be here. Thank you for those of us joining in person and also online. And thanks, Stephen, for doing such a great job at emceeing, and to Lymphoma Australia for hosting this evening. I'm really excited to be able to share some interesting tidbits about what might be new in relapsed or refractory follicular lymphoma. But first, to start off, because whilst many of you may be very familiar and have a great understanding of some of the terminology we might be using, I'm mindful that there may be many of you here or online for whom this is a new journey. And so just to clarify what I'll be speaking about, when we talk about relapsed follicular lymphoma, this is when somebody's lymphoma may have come back after having been in a period of remission. And when we say refractory, we refer to the fact that sometimes lymphoma may not always respond to the current treatment and may indeed stay the same or even spread further during treatment. So those are the types of therapies we're going to be talking about this evening to address those situations. Some important things to think about in anyone who presents to us with relapsed or refractory follicular lymphoma is firstly recognising how long it's been since their last therapy. And as Professor Trotman outlined already this evening, certainly we experience that many of our patients may have had one line of therapy and remain in remission for many years. But there are that smaller proportion of people that Prof Trotman spoke about who might relapse sooner, and in particular within those first 2 years after finishing their treatment. We always think about performing a second biopsy, really to clarify, are we still dealing with the same disease? Or has there been any transformation into a different or more aggressive or faster growing type of lymphoma? When we've established that indeed we're still dealing with follicular lymphoma, the important thing to remember is that just because you've got lumps or bumps back or some evidence of the disease, you may not necessarily require treatment immediately. So thinking back to that phrase we used about watch and wait, that may well be absolutely the same scenario if you present again with relapsed disease. But indeed, we follow you closely to consider whether there's any development of new symptoms that may require treatment. Now in Australia, our standard second line therapy is really not too dissimilar from what you may have had the first time around. And that's to say a combination of immune and chemotherapy. And as Angeline beautifully outlined, those indications that tell us, does somebody actually need some treatment? We use particular guidelines that Angeline went through nicely in detail. I've summarised them there. We call them the Guelph or BNLI criteria. But practically speaking, it's, do you have lumps that are really big that are pushing on important parts of your body? Do you have symptoms like those sweats or fevers or changes in your blood counts that mean, right, it's time to start some therapy for you? And as I said, when we think about conventional treatments, the immuno and chemotherapy, you'll now be familiar with many of those names, a combination of those antibody treatments and the chemotherapy backbone, as we refer to. In combination, we know are highly effective. The other important part to consider is that if follicular lymphoma returns, there may be a small proportion of patients who are young and fit that may be considered for what we call high-dose chemotherapy and an autologous stem cell transplant. And that is where we use big doses of chemo to suppress as much as is possible and use your own stem cells as a rescue remedy to grow that bone marrow back again. But increasingly, with lots of novel therapies becoming available, this is less and less common. The picture we've got up on the screen there looks a little bit complicated, but the important really part of this message is that there are some really exciting new therapies on the horizon. That lovely pink blob in the middle there represents your follicular lymphoma cell. And all of those diagrams around the outside are really just to demonstrate where in that cycle or where on the cell these targets are being used. And if you'll forgive me for lots of military analogies this evening, essentially, when we think about chemotherapy, it's a bit more of a blunt instrument. We know it works beautifully and often keeps people in remission for a long time, but it might be a bit more like a hand grenade we throw in there. It takes out the bad guys, but takes a few of the good guys out in the process. The aim and the hope with some of these more targeted therapies is thinking about them a bit like a sniper, aiming really directly for those different receptors or targets on our follicular lymphoma cell, with the hope that they're very effective, but hopefully have less impact on the rest of our body as well. So there's three particular areas I was going to outline for us this evening. Firstly is some of the additional types of monoclonal antibodies. You've heard Angeline and Judith already this evening talk about rituximab and obinutuzumab, which are some of the antibodies we commonly use in practice, but there are also some new players on the horizon. There's also some novel targeted medications that we'll outline, as well as some really exciting new therapies that enhance our own immune system to fight off follicular lymphoma. So starting off firstly with these monoclonal antibodies, this is, as I said, treatment that targets specific proteins on the surface of our B cells. CD20 is the particular little marker, as you can see circled there, that is targeted by rituximab and obinutuzumab that we've heard about this evening. But there's also a new target for another antibody on the surface of our B cells called tafasitamab. And I know we keep coming up with names that are a little bit more tricky to pronounce, but some really exciting new combinations to think about as well. Lenalidomide is another medication in our arsenal, and whilst we don't have access to that in routine care for relapsed lymphoma just yet in Australia, it is available already in other parts of the world, in the UK and in the US, and so we know from lots of clinical trials that this is a highly effective treatment for follicular lymphoma, and we usually pair this with one of our monoclonal antibodies, rituximab. Lenalidomide is a tablet, and it's taken for 3 weeks out of every month of therapy. And rituximab is given every week for the first month and then once a month for a total duration of a year's worth of treatment. As I said, it's effective and well tolerated and is currently available in clinical trials in New South Wales. One of the other families of medications, circled again on our lovely diagram there, are what we refer to in smaller form as PI3 kinase inhibitors. Now, these are a family of medications that, as you can see there, work on some of the downstream signaling that affects our B cells. We know from clinical trials that they seem to be quite effective at treating lymphoma, but for certain members or cousins in the family of these medications, there have been some issues with side effects. So things like inflammation of some other parts of our body, the bowel, the liver or lungs, which in certain situations could be quite severe. And the first member of the family in this of treatments called idelalisib was actually withdrawn back in 2022. But there are some of the other new cousins in that same family that are still involved in clinical trials. So watch this space. There may be others that indeed work better and hopefully have less side effects. Tazemetostat is another oral tablet, and this is a targeting therapy that works at inhibiting the activity of a particular protein involved in these B cells. It's a key enzyme that helps in regulating how genes are expressed in our cells, as well as how they grow. And so really it acts by helping to stop those cancer cells from growing and spreading. And whilst, again, it's not routinely involved in standard of care uses yet, there are some clinical trials ongoing in Victoria. Bruton's tyrosine kinase inhibitors, or indeed degraders, which are the new players in this family of medications, we'll start with the inhibitors. These are medications that work by binding to what we call the BTK protein that's involved in our B cells. And BTK inhibitors block the activity that leads to growth of these B cells and therefore causes the malignant B cells to die off. Similarly to some of the other medicines we've spoken about, it's also often combined with monoclonal antibodies. And indeed, we currently have a clinical trial open in New South Wales that's looking at a combination of one of these medications called zanubrutinib in combination with obinutuzumab. BTK degraders are, as I said, a new player in this family, and instead of blocking the effect of the protein, these medicines actually target and eliminate the protein, removing it from the cell. And excitingly, there are also clinical trials currently available and open in New South Wales, looking at how well these medicines work in many types of lymphoma. So immune therapies, and I know many of you probably would have read news either online or heard a little bit about some of these different types of treatment. And certainly they're really exciting because they work at trying to enhance our own immune systems to fight cancer. And two particular types we'll be speaking about briefly this evening. The first being bispecific T-cell engaging antibodies, and the second, chimeric antigen receptor T-cell therapy, or CAR-T for short. So first, to think about bispecific T-cells, what do we mean when we say that? You can see at the top in that diagram a bispecific antibody, and it probably doesn't look too dissimilar to some of the other monoclonal antibodies you've seen already on the screen this evening. The idea behind these antibodies is that they target two different types of receptors. One that's found on the surface of our T lymphocytes, which are the chiefs of our immune system, and the second on the surface of some of our cancerous B cells. And what they essentially do is to bring those two cells nice and closely together. And that allows the release of some enzymes that basically allow our T cells to get a little bit stirred up and realize there's some baddies in the neighborhood, we better get onto it and kill them off. And it's a really effective way of killing off those lymphoma cells. There's some pictures just down the bottom of that diagram there, looking at some of the antibodies that are already involved in clinical trials. Across different types of lymphoma, but in particular for follicular lymphoma. And so you may find some names there that if you've done some reading or are really interested in these types of therapies that may be familiar to you. So mosunetuzumab, epcoritamab, glofitamab, and what have we got there? Odronextamab, a bit small on my screen. And this is just a really lovely picture taken almost down a microscope at looking how those receptors bring those cells close together to be able to start that activation of the immune system. Now, a busy diagram here, but really what I wanted to describe is how many of those medications are currently involved in clinical trials. Now, this even is a little bit old. It's from a paper from last year. And so you can see there that several of those agents are involved in treating follicular lymphoma. And so it's really exciting for us to get more and more information about how these might fit into our treatment algorithm for follicular lymphoma. Importantly, because you'll see some of those trials, they're labelled phase 1, phase 2, phase 3. What does that all mean? When we talk about phase 1 clinical trials, that's where we're trying to work out that medications that are new are safe. Once we've established that, we then move on to our phase 2 trials, which focus on how effective are these treatments in this particular disease. Once we've established that they're effective, we then compare them with our standard of care treatments to work out, do they actually work better than what we have already? And phase 4 basically is checking on how effective things are once they've already been approved and making sure they continue to be effective as they roll out and are used in greater numbers in the population. But hopefully that also just illustrates to you how carefully these medications are tested and trialled and checked so that by the time they get through those clinical trials, we know that they're safe, we know that they're effective, and we know that they're at least as good as, if not better, than what we had before. Now, clinical trials are open in New South Wales, utilising some of these types of medications. So it's really exciting for us to glean more and more information about where they might be best used. Particularly as Professor Trotman highlighted, we always think about that trade-off between how effective treatments are versus what the types of toxicities they may result in, and balancing that trade-off in patients depending on your background history or other factors that play into decision-making in terms of treatment. Now, CAR T-cell therapy. Essentially, this is, again, an exciting new type of technology where this is an immunotherapy that re-engineers a person's own T-cells, remember the chiefs of the immune system, to recognise and attack those cancer cells circulating in your body. And essentially, it's like producing your own super soldiers, your own little Arnold Schwarzeneggers to go and work on your lymphoma. And again, excitingly, there are clinical trials currently open in New South Wales. How does this therapy work and how do we make these CAR T-cells? Well, this is just a simple diagram to take you through that explanation briefly. The first step is actually collecting your own lymphocytes, and that is performed in an apheresis unit in your hospital or wherever you have undergoing your treatment, whereby you get hooked up to a special machine that filters your own T lymphocytes out of your bloodstream. They then get sent to a manufacturing facility where they are re-engineered to become those little super soldiers. And basically we do that using special types of viruses to introduce extra DNA, think Captain America style, to make those cells stronger and better fighters. Now, Professor Trotman and I actually had a great opportunity to go to one of these manufacturing facilities late last year and to see the amazing way in which those T cells are changed and then manufactured and expanded before they come back to the patients that they're going to be re-injected into. The step 4 up there is chemotherapy and infusion. Now, what this means is when we've just about got your cells back, we need to prepare the body for that next lot of therapy. And again, using a bit of a military analogy, it's a bit like sending out the artillery in advance of an attack. We kind of want to flatten the ground a little bit so that by the time those CAR T cells are ready to go, they can take action straight away. So once that infusion has happened, the infusion then of the CAR T cells takes place. And they look a little bit like this when they come back to the bedside. Not a very big or exciting bag, but lots of power packed in there. Now, as we mentioned, it's really important to think about what potential side effects might happen from these therapies. And really, they come as a result of that activated immune system. The 2 particular important ones to know about are what we call cytokine release syndrome. And this is, cytokines are small proteins in our body that know when there's an immune response that's needed. And they play an important part in communicating between the cells when our body's under stress. And that can happen when we've got inflammation, sometimes infection, or even trauma. But when we have cytokine release syndrome, this inflammatory reaction affects the whole body. You can imagine as these cells are reinfused back and are getting down to their fighting. So patients may have fever, feel quite fatigued, or be a bit nauseous, have a rapid heart rate, low blood pressure, or indeed sometimes a little bit of difficulty breathing. And we have medications that basically are a bit like firefighters. When there's been a big battle, we kind of try and calm down the fire that's going on just to settle down some of those symptoms as the CAR T cells are doing their work. The second important type of effects are what we call ICANS, or immune effector cell associated neurotoxicity syndrome. Now, similarly, this is related to those inflammatory cytokines, but they can also affect our brain. So people might have headaches, feel a bit confused, feel a bit weak, and in much more serious instances can have things like seizure or have a reduced level of consciousness. And again, we have medications to help calm down that inflammatory reaction in the body. So an important summary, having heard a lot of brief information about some of those new therapies. Whenever someone comes to us again with relapsed or refractory disease, we ask ourselves some important questions. Number 1, are we dealing with the same disease? So you may need a repeat biopsy to clarify that. And if so, how widespread is it? So we might perform an additional scan, one of the PET scans that Angeline showed us on the screen, to clarify where your lymphoma is and is it causing any impact on your body that might need some treatment. So the next step, are there symptoms or signs that mean that you might need treatment for your lymphoma? In other words, the when. When do we need to get started? Or can we actually just monitor your symptoms and keep an eye on you, continue with that watch and wait, because the disease may not be causing any mischief immediately. The important thing to remember is that every individual person is different. People will have different background medical histories, of different ages or fitness, and social situations. Whereabouts do you live? How easy is it to get to a treatment centre? What types of treatment are going to be best suited to you? And really, that's an important part for us to consider. Is standard of care an excellent option? We know there's great evidence behind it and it works well. But also, importantly, and I'm sure you've probably gleaned from us this evening, we're a really active research unit here at Concord, and certainly statewide and countrywide. Australia is a great place and a very enthusiastic place for clinical trials. And so we'd always encourage you to think about and speak with your doctor. Right, if I need some treatment, what are my options? And can we talk through what might be best for me? And we talk about that as being our shared decision making, which is so important when we're thinking about treatment and what is going to be best for you as an individual. Now, finally, we've already alluded a little bit this evening about some of the ways that we partner together with you as our patients in research, because I think it's pretty extraordinary when we can get together disease experts and partner them with experts living with the disease to find out more and to have helpful information about how best we help people moving forward. Professor Trotman's already described some of our involvement with a more rare type of lymphoma, Waldenstrom's macroglobulinemia, with the Whimsical Research Project. Dr. Nicole Longdu also heads up our My Hodgkin, My Health project. and we've alluded to already this evening, Followed for Life. And we're really excited to be able to move forward with this project with the aim of capturing what we call de-identified data. In other words, we don't know who you are or where you're from, but you're able to give us some really important information about your disease, about what treatment you may have had, the impacts of that treatment in terms of side effects, and indeed just the impact of having your disease. All of that information is so helpful for us to know how best to help the patients of the future and the people living with follicular lymphoma. And so we're really excited if there's anyone in the audience here tonight or indeed watching online, any experts in terms of mobile technology or enthusiasts, we'd love to hear from you as we develop and move this project forward. And indeed, we'll also have our website at some stage for us, Alfredo, just to let people know our clinical research unit's contact details as well. But that's it from me this evening, and thank you so much.
Janelyn, while our panel gathers, I have a question. What can we do to advocate for these new therapies in government and get our government to open the wallet, let's say? Does writing to our member actually help?
Thanks, Stephen. Well, look, we're big advocates of patient power and patients being empowered with education. But certainly I think there are important bodies as well that help to represent you. Number one on that list tonight being Lymphoma Australia, who are fantastic at providing that advocacy, but also being involved in clinical trials where those treatments become available and we learn and understand more about them. But certainly, being well informed, being well educated, and knowing how best you can contribute to moving that information and that knowledge forward, I think is crucial. Move so we can see everyone.
We were hoping that the CEO of Lymphoma Australia, Sharon Winton, might be online and able to answer that. And Sharon has for well over a decade been a very passionate and effective, very strategic advocate for lymphoma patients across Australia, and harnessing with her board and her team of nurses, of whom one is here, Nicole, who you've already met today, in educating, supporting and advocating for lymphoma patients globally. Will you give us your response to how Lymphoma Australia effectively advocates with the health technology assessments and approval groups for these new therapies?
Yeah, thank you, Professor Trotman, for the question. And this is a wonderful audience, and it's also the fact that follicular lymphoma, when I think about the treatments that were available a decade or 20 years ago, we've had so much progress. And to everybody who's listening today, I would say exactly what Professor Trotman was saying. This is a long game. And one of the reasons why it is a long game is because of the new treatments that have been developed. But what we need to be doing in Australia is ensuring that those treatments are also available to Australian patients for when you need them and when our clinicians need them as well. So to help us, sometimes what we will do, we'll see a new treatment might be coming up for follicular lymphoma. We'll put a call out to the patient community, and you are able to make a submission to the people who make those decisions and tell them about your experience with lymphoma and why you need that new treatment. But look, I think we're in such a great place at the moment with all the new treatments. The challenge for us sometimes is actually trying to help patients understand what is going to be the best treatment for you. And today has been an absolutely wonderful explanation of all of that information. But now it's about going back to your clinician as well and asking about what is available, a clinical trial, what are the new treatments? But otherwise, yeah, there's so much we can still do, but we've come a long way in Australia with all the support that we get from our patients, clinicians and organisations like Lymphoma Australia.
Thank you so much, Sharon. I'm actually going to, if you don't mind, Stephen, moderate these questions, starting with the questions related to initial therapy. But one of the first questions that we've got online, and we'll give the online people the first go, relates to sort of how do we choose between rituximab with chemotherapy compared to obinutuzumab with chemotherapy, given that they're both CD20 antibodies. And rituximab was the first in class. Obinutuzumab is a slightly different engineered properties, and in general is a little bit more effective at kicking the can down the road, so to speak, giving you a slightly longer remission than you would if you had rituximab with your chemotherapy. But that comes at a cost. As always, you know, there's a saying in life, you can't have your cake and eat it too. Unfortunately, there is a bit more toxicity in terms of low blood counts, anemias, low neutrophil counts, that often patients need to give themselves injections to support their neutrophils and keep their protection against bacterial infections strong. That's more common with obinutuzumab, along with more of those troublesome, not risky or particularly serious, but very troublesome infections like sinusitis and bronchitis, those minor respiratory infections. And then there was another question that came, and this is a really great question. It says, well, if the progression-free survival is better with some treatments, why isn't the overall survival better? And we believe it's probably because with treatments like rituximab maintenance or obinutuzumab maintenance, you're effectively still continuing with treatment. And eventually, when you relapse or your disease comes back again, it's just that little bit more resistant to the antibody treatment the next time you have it. Janet, would you like to add any further comments that have sort of come through your mind as I'm sort of talking about rituximab versus obinutuzumab?
No, I think that's something.
Yeah.
Yeah, absolutely.
So what I might move on then to talk about relates to, in fact, I might get you, Ryan, to help me moderate through these questions. There was another one about what lifestyle choices and changes could we be making now to give us the best chance of a longer period of remission and reduce the chance of transformation. And that's a question we get asked so many times. And my answer to that is, unfortunately, there is nothing that we can do that will change other than the treatments, whether it be maintenance antibody treatment after induction treatment, after the initial therapy. There is actually nothing we can do to change the preordained genetic behaviour of that lymphoma. But there is certainly a lot that we can do to keep ourselves healthy and be ready if it comes back again. And perhaps, Janlyn, you might like to sort of comment on, you know, keeping yourself well in that prehab before chemo and then the prehab or the rehab after chemo.
Great question, team online. As Judith said, I think it's so important that there may not be anything we can do about the disease itself, but what we can do is keep ourselves as fit as possible and as well and as healthy all round, so that if and when we do need more treatment, we tolerate the best of treatment that's available to us at that time. Particularly with this ever-changing and broader categories or new types of therapies, we want to be in tip-top shape so that if we ever need it, we know that we can tolerate the best available treatment that's there for us at that time. So I think that's, again, fitness after treatment. We know that there's a period of rehabilitation while you're recovering, and it's such a good way to work through some of those side effects you may have had during treatment as well, to focus on your overall health. Be outside, have some exercise, eat well. It may not impact your lymphoma itself, but it's going to impact the rest of your life. And as Professor Trotman highlighted, we're in this for the long game. Many people with follicular lymphoma, it might be other diseases or other things that actually play more of an impact on your overall survival and your life expectancy. So, you know, making sure you optimise all of those things is just as important.
And isn't it argued that, and there's some data, isn't there, that, and perhaps you can comment about this, Nicole, and the sort of questions that you get as a lymphoma support nurse, is that people who then go on a bit of a health kick after they've had treatment and address all the other risk factors to their very survival start thinking about their weight, thinking about their smoking, thinking about how much they're drinking, those sort of healthy decisions.
Yeah, that's definitely something that we get a lot of phone calls about as a lymphoma nurse. People want to know what they can do to best prepare themselves for when they do potentially need treatment, or when they're going through treatment or post-treatment. And what we always recommend is eating, a healthy diet, checking in with a dietitian. A lot of hospitals do have dietitian facilities available. Getting an exercise regime if they're not already exercising, maintaining a healthy weight, preparing yourself for when you do eventually, or if you do need to have treatment. And then through that treatment as well, being able to maintain that as best as possible. We just want you to be looking after yourself and doing the best things to nurture yourself as well.
Thanks, Nicole. I'm now going to move on to a question online about PIFU, but actually, no, before we do that, it's been a bit unfair. We've had all these wonderful people who've actually come to be in the room, so we're not talking to a computer screen. Who would like to put their hand up first to ask a question? Camera's coming your way. Sorry, the microphone.
Is it on?
Yes, it should be on.
Yeah, hi, Charles Tees. I'm a 33-year survivor of follicular lymphoma.
33 years and looking pretty healthy.
And it's had 3 goes at me. I've just finished 3 years of 6 cycles of R-CHOP 21, followed by 8 cycles over 2 years of rituximab. My question is, and it's probably a hard one to answer, I'm in remission again. I get treated out of Crown Princess Mary at Westmead. In the last 3 years, I've had probably 6 different types of skin cancer. And I've been told there's an incidence of that now. I'm trying to understand why. I've had 2 squamous cell, major facial surgery 14 days ago, and also one on the scalp as well. And I've been told that they're going to continue. I'm a high-performance coach with Institute of Sport. Fitness has been a big focus for me, lifestyle medicine, right through. I've never been sick. I've never had nausea, nothing during all of my treatments going back to 92. So is there something I should be doing to restrict, without going out in the sun, of course, and getting sunburn, the onset of these skin cancers now? They're going to keep coming, I've been told.
Charles, I'll be very interested in what my colleagues have to say in response to that. But I think the reality is, Charles, as young looking as you are, it was pretty much the sun exposure that you and I and so many of us had as children, as young adults, before we ever had any concept of SPF 50, that effectively established our high risk of skin cancers.
I'm guilty.
We're all guilty. Yeah. We're all so very guilty in Australia, and it's something that we can't undo, other than trying to prevent further sun exposure. With the whole slip, slop, slap going forward. Because unfortunately, when you have had chemotherapy, you do have a higher rate of, subsequent cancers.
I've got good surgeons, so as long as I get checked.
Okay, another question.
Yeah, I've got a question actually for Dr. Lowe. You mentioned about anxiety. So, as you know, I'm a patient and I've been on the clinical trial, and I'm still on the clinical trial. Been on it for 8 years now. So, thank you. Thank you to everybody. The anxiety, I think we could all probably relate to this, that we all get nervous before our results, and when we get our results, we're like, thank you, or we're up and down. But the biggest thing for me personally, for anxiety and the reassurance, so would it be a question that for myself and everybody else here is, when we're in, obviously seeing you guys, the doctors, is to ask what's next if my trial doesn't work, or to ask what's the next stage or next therapy to ease the anxiety. Would that be a fair question to ask you guys?
I think it's a totally fair question to ask us, and I'd like to think, and Professor Trotman has told me this as well, that we should always be thinking about what's the next step. And hopefully we always discuss, and if we don't, that's definitely something you should be asking us. If that's a question on your mind when you come to see us, please ask that question, because it's our job to be thinking about just one step ahead. Even though if there may be no signs that the disease is coming back, it's our job to be thinking, if it did, what's the next step? And we should be thinking about what is available in Australia at the moment and what are the clinical trials that are available. But yeah, please ask. It's a really good thing to do. Because sometimes that can alleviate anxiety, because you know that there is, if the disease does come back, then we do have an option. And there may be multiple options, and there may be even options after that. So yeah, please ask.
We do often say to patients, it's my job to make sure you have a plan B. Or sometimes I have to say to patients, it's my job to make sure you have a plan D. And sometimes as Dr. Lowe, sorry, Brian, please could people stop calling me Professor Coleman. None of my patients call me Professor. I think sometimes I say to patients, it actually pays to not catastrophize, but think, what is going to happen if the lymphoma comes back, and to map out that plan, that very clear action plan. And the thing is that when you tell your patient this is likely to be the plan in 2025 if it relapses, you also have to say it might not be the plan in 2030. Shannon, do you want to comment on that?
Yeah, the only other aspect I'll bring to that is, as Ryan outlined, the PIFU system, and I had some experience working with that system in the UK as well. The other side of this, of course, for people who've been living with follicular lymphoma, sometimes for many years and haven't needed treatment, is that there also is real benefit in being able to get busy living and taking out some of that institutionalised feeling of coming to hospital every 3 months and feeling anxious about it. Taking that ownership of your own disease, being well educated, knowing you've got communication straight back to your team if needed, often, in my experience, allow people to get busy living their best life, having been in remission for some time, and really just feeling a bit more normal again. And so I think there's also that importance in knowing that we do a lot of the worrying for you, and that we're always here to talk through any questions you have, as Ryan said, but also to really aim, our aim in being able to get you through your treatment is to get you well again and enjoying your life.
Judith, I've looked at all the questions online. I think there's a couple that are recurrent ones. Go ahead, Emma, can you ask those questions sort of on behalf of sort of...
Yes, I was just saying, I was looking at the questions online, and there's a couple of recurrent questions on how often during monitoring should you be having CT scans, PET scans? Is there any benefit of doing them regularly? Do they pick up recurrences earlier? We all get asked this by questions all the time, and I think it's worthwhile. There's a few questions online to address this.
This is so hard to answer, and there's a different answer for every patient. But for the vast majority of patients, we don't do CT scans as routine for monitoring of their remission. We don't want to induce anxiety before they have their scans. But there are a few patients in whom perhaps if they've had very bulky abdominal disease that affected their kidney function or caused, significant sort of silent effects before their initial presentation, where we might get a CT scan as a baseline after they've finished all their treatment, quite a few months after their PET scan, to show us the sort of the anatomical layout of that originally bulky disease and what little nub of tissue is left. And then maybe a couple of years later, we might do another scan. It's entirely up to their comfort levels with their own monitoring of symptoms and, how they feel about scanxiety, having contrast, whether they actually, really want the scan for reassurance before they head off overseas for a year or so. So it's a by negotiation, but generally we try and avoid scans, except for in that situation. In the patient who's had lymph nodes in their neck or their groin that are very easily felt initially, then they've got their own way of detecting a relapse. very occasionally, I will also do a scan before I send the patient off for PIFU as a new baseline in case it needs comparison in 5 years' time if they come back with a relapse. Janlyn, can you expand on that? Because it's so hard, isn't it, for each individual patient to work out with them how to do the scans, if at all.
Yeah, I think you captured that really well, Judith. I think, as you say, really, as we know, follicular lymphoma is, as Judith said, a heterogeneous disease. It's different in every person, and every person is an individual. Where is it located? What sort of symptoms did you have when you presented? And how easy is that to pick up with our usual clinical examination and blood tests and history taking? But we essentially always want to, again, think about the efficacy of doing that and the toxicity of doing it. Having lots of scans and unnecessary radiation often doesn't actually change how well we're able to look after you, except for those specific instances that Judith mentioned. So I think really it comes down to our individual chats with you, going through what's coming up in life next, what's happening generally, and is anything that needs a little bit of deeper digging to get to the bottom of it.
Judith, there's another question which I think is a great one about clinical trials.
Yes, I love that one.
Yeah.
So this is a fabulous question that I'm going to read out in its entirety. Well, the first question. Are patients only able to access clinical trials after being treated with standard therapies first? And the answer to that is no. Clinical trials, clinical research is deeply embedded in the practice of many, in fact, every haematology department across Australia. There is a very strong philosophy of clinical trials as embedded in routine clinical practice. You met Stephen, who had a clinical trial after watch and wait, and as his initial therapy, he was randomised between two standards of care, having standard antibody chemotherapy and maintenance, compared to having standard antibody chemotherapy and no maintenance, because we want to work out what the trade-off is between that progression-free survival advantage and the toxicity of the maintenance therapy. So clinical trials can occur in the watch and wait patient, can occur in the first line setting and in the multiply treated setting. And what is wonderful about the marvellous collaboration that exists amongst the haematologists across Australia is that if we feel that there is a clinical trial that you should be screened for, that is at another hospital down the road, reasonably close to where you are, we will actually recommend that you go and meet the haematologist at that hospital and talk to them about the clinical trial. And that's called screening, to see whether you're eligible and whether indeed the trial is something that has appeal to you. Because what we're all very focused on is trying to offer you the best therapeutic options for you. And that might not be what we have available right here and now at Concord. Ryan is our clinical trials fellow. Would you like to make any other general comments about clinical trials participation? Perhaps, reiterate Janlyn's mentions about the different phases of trials.
Yeah, as Judith said, there are trials for follicular lymphoma come at any stage. So yeah, if you first need treatment or later on. And there's different type of trials. So as Janlyn was saying, so these phase 1 trials, which are probably less common, but they're when a drug is first developed. And we're trying to see, first of all, if it's safe, and also looking to see if it works. But it's more about safety. And then that drug will move through the different phases. And then eventually it gets to a point where you need to compare this new drug to what's available as a standard. And you want to see, is it better than what we have out there, okay? And that's what some of the trials that you guys have enrolled in here. So yeah, always, I think whenever you're talking to your doctor, you should ask, are there any clinical trials for me? Is there anything available? If you're willing to travel, say, I'm willing to travel somewhere if there are trials. So I think, yeah, it's all about shared decision making, as we said.
And a question we often get about, what if I'm randomised to observation or placebo? How do you respond to that, Ryan?
Well, we wouldn't enrol you on a trial that we we're worried about if we thought it was substandard. So as I said, this is always about comparing to what we know is the best available at the moment. So yeah, we would never. Trials don't exist to enrol you onto something against us that we think would be in detriment to you. So yeah, hopefully we reassure you about that.
So effectively, when placebo or watch and wait is actually a standard of care, is the only time that you would ever be randomised to that. Emma, you're curating the questions. Have you got any other questions online that you'd like to think of while we see if there's any others in the room?
Anybody else here like a no?
I couldn't see it. There were a lot of specific questions where people had been on this particular,
Not the thing.
but I think maybe getting some feedback on Ryan's talk about the PIFU and what people's anxieties and thoughts are potentially around that might be a good idea.
Yeah. Does anyone have concerns about PIFU? Does that?
I'll answer this. There was a question online. I think it was. I can't remember the details, but it was someone who sort of said when they were first diagnosed, it wasn't really clear what symptoms they had that suggested of them lymphoma. I think they had some night sweats that were thought to be related to the menopause. So how would they know if their lymphoma had come back? I think that's a really good question. And I guess the first point I would make for that is that patient-initiated follow-up isn't for everybody. And as I said, one of the reasons that we would put you onto it is if you were agreeable. And if we thought that this wasn't the right sort of follow-up for you, or that you had real anxieties about how your lymphoma came about, because everyone's lymphoma is different and the story of how you got to your diagnosis is different. So it's only if you're agreeable would we think about putting you on patient-initiated follow-up. And yeah, it's about having awareness of what your symptoms were at the beginning. And if we think that it will cause more anxiety by allowing you to sort of initiate your own follow-up, then we wouldn't do that.
There's a question here too.
Just a further question about that. If you go on that, is it like every 5 years you're going to contact us just to see how we're going?
Nope. That's a really good question, Ken.
Yeah, and also
it
just to make
literally
sure.
is initiated by you, and
Okay,
that's yeah.
but okay, if you know, 33 years over here. So if you go for a long time, how do you know who you're talking to?
I think that's a really good question, and that's a really good challenge that maybe we might have to consider actually thinking about how to address in the Follow for Life app. So remember that, Ken, as one of our patient investigators in the app, that that's a really good way to potentially provide a PIFU platform. Yeah.
And just last comment to address to Ken there, I think the other important team member to remember in all of this is our wonderful GPs who work in the community. And so if it's been a long period of time that you haven't seen your haematologist because you've been really well, which is excellent, always know that if you've got new symptoms, you're not sure if your haematologist is still working in the same place or you've moved to a different part of the country or overseas, your GP is always your first community champion who can refer you straight back to see someone new or back to someone you know already. So I think it's really important we remember that they're also so involved in the care process as well.
I just wanted to say sometimes asking questions can be a little bit, I guess, daunting or not something that comes naturally for everyone. So always reach out to us at Lymphoma Australia. You can talk to someone like myself or Liz one-on-one, toll-free number, Monday to Friday. And if, for instance, we don't answer, if we're on another call, we will call you back within 48 hours as well. Or you can write us an email as well, because sometimes you just need that person to talk to and run some things by, and we're always there to support you. Thank you.
That's another great resource for PIFU patients.
Yes, very good resource for PIFU patients. Yeah. So yeah, thank you for everyone for attending this evening. Lymphoma Australia really appreciates it.
Thank you, everyone. As we close this webinar, I would like to share with you that I am eager to contribute as a patient research partner in the development of the Follow for Life app.
Oh, yes.
Thank you. I've been recruited. transforming my personal story and those of thousands of follicular lymphoma patients globally into de-identified aggregate data, and that will provide genuine long-term survivorship follow-up. This big data will inform the outcomes of sequencing of the novel chemo-free therapies that we've learned about today. If you possess the skills in marketing, design, social media, research, or app development, or simply have a keen interest to contribute, I encourage you to join the focus groups for question design or participate as beta testers. Please don't hesitate to reach out to Lymphoma Australia or Dr. Falconer and Professor Trotman and the lymphoma team here at Concord Hospital at the above email address. I'm deeply grateful to our co-hosts, Nicole and Liz from Lymphoma Australia, for co-sponsoring this event, and our esteemed speakers sharing their knowledge. And to all of you, again in the room and online, for your active participation. The journey with follicular lymphoma is not one we face alone. We are a community united by shared experiences and strengthened by mutual support. Together we can face the challenges ahead with resilience and hope. Do stay connected to Lymphoma Australia and your local lymphoma communities, and continue seeking knowledge, advocate for yourselves and for others. Thank you once again, and to the 150 or so people online that joined us today. I wish you all the very best in your journey, and I look forward to the continuing progress that we can make together. Thank you.
We are very, very proud that this is the first time we have ever had a patient MC in education. And Foundation for a Bloody Great Cause, thank you for our lovely sandwiches. Thank you all. Huge stamina to be in the room and online for 2.25 hours. Well done, all of you. Thank you.